Okay, good afternoon class. Today we'll discuss the drugs for heart failure. Since we've already discussed about the etiology, pathophysiology of this, we'll go directly to the drugs. So, the drugs for heart failure could be those with inotropic effect, tsaka yung without inotropic effect. When you say inotropic, that is the force of contraction. So, let's start. Inotropic effect, the main drug for this one is the digitalis. This is familiar to you class because this has already been discussed in your PCOG. If you still remember, digitalis, there are two sources for this one. Actually, this is a genus that contains cardiac glycosides, which are responsible for the inotropic effect. Okay, again, this is medicinal chemistry. Cardiac glycoside is the main thing that gives effect, the main reason of the effect of contraction. So we have two sources here. We have the digitalis purpurea. We also have the digitalis lanata. When you say purpurea, P for poisonous. Okay, this is not being used in the market. This is not marketed to the public because of its toxic effect. The drug, the example for this, the drug that could be made out of this plant is the digitoxin. Well, this lanata, when you say lanata, lana poison, so that is digoxin. Okay, this is marketed in the public as oral, tsaka suspension, with a drug name, brand name, lanoxin. That is very common in the market. Okay, so the prototype for this drug is this, digoxin. Okay, remember, this is the prototype. Okay, so there's the botanist behind these two plants who discovered that it could be a good medicinal for contraction, for a drug that has inotropic need. So it is William Withering, a botanist. And then there's also what you call carbinolides. So carbinolide class also contains cardiac glycosides. Okay, contains active cardiac steroids. Who are these? Who are the drugs under this one? We have the Oubain, oleandrin, and the bufalin. These are the three drugs under carbinolide. Okay. So if we look at the medicinal chemistry class, we have medicinal chemistry. These drugs, digitalis, contains a glycone, sugar, steroid, and the lactone ring. This gives this effect CNS. So it's more makasulod siya sa CNS. Therefore, this is very they have the adverse effect na makakos og mga CNS related like saman ng hallucination, sedation, anything is related with CNS. Aside from that, this is not extensively metabolized in the body. When you say it's not extensively metabolized, it is excreted and changed in the kidneys. Okay, so aside from that, because naaman siya diri CNS effect, mas dagan siya toxicity. But compared to the digitoxin, mas na lang siya, okay na lang. And it has, these two drugs has a high narrow therapeutic index. Do you mean by that? If ang tambal ganit niya is malapa sa window, kay possible gid siya nga mo shoot up din ang mga adverse effect. So lisod din siya if dili siya ma-monitor. Okay. So let's go to the next topic, the pharmacodynamic. Unsa may gamit ani niya na relate niya sa heart failure, pharmacodynamics. So here, if you remember, we talk about the transportation, how calcium gets inside the cardiac cells. So there are three transport. And let's say like that. So this one, this is the exchange between the sodium and potassium. Yan, baliktad. So sodium, normally it's piso, right? Potassium in, sodium out. Okay. So when the sodium goes out, potassium goes in. The sodium also goes back inside through this another channel, and then another also transports outside is the calcium. Then here, once na sa calcium sa gawas, there's also a pump na makapasulod balik ni calcium. Who are these three? First, this one is called a sodium pump. Sodium pump. Or the sodium potassium ATPase. And this one, this is what you call NCX. What is that? Sodium calcium exchange. And then this one, this is what you call L-type, voltage gated channel. Okay. So once calcium no muso dire sa cell, inside cell, outside ni sa gawas. So there's what you call here a small receptor. Mo-accept siya sa calcium entering the sarcoplasmic reticulum. This is what you call SERCA. Again, study what's the meaning of SERCA. And then once the calcium gets inside, it is binded to a sequestrant, that is Chi-S. And then there's one receptor here responsible for releasing the calcium inside the sarcoplasmic reticulum whenever the body, whenever there's a trigger or a signal na or alert nga kailangan na og calcium to contract, to have the contraction. So here, calcium it goes out, and then ano siya, ma-desynthesize siya dito, synthesizer siya dito sa actin and myosin. Then once this actin and myosin interacts, they become complex. Okay? Myosin, troponin, complex. And then, what happens next? There will be contraction. Okay. So, for digitalis, we block this one. Why? In order para si sodium dili na magawas. So there will be increased sodium inside the cell. Once there's an increased sodium inside the cell, the calcium na sa dili di na pud magawas. So calcium stays. So there's an increase in calcium. Then right after, kung daghan ng calcium diri sa iyahang cytoplasm, it goes inside this sarcoplasmic reticulum. Therefore, increase calcium stores. And daghan pud ang ma-release if there's a trigger or an alert nga kailangan siya mo-release og calcium. So that is how this digoxin works. So very inotropic. Since by looking at this mga electrolytes nga daghan diri calcium, if too much calcium this would lead to hypercalcemia. Yes, hypercalcemia. But we'll talk that later. So there's also a concern, electric conductance. So ano kahano nga mo pump gid ato ang heart. So this is the idea, electric conductance. We have this. So electric conductance is divided into two, the direct saka autonomic. When you say direct, kung ang connection, this will connect the electric conductance with the digitalis, especially digoxin. So the electric conductance resulting from taking with digoxin there would be direct. So what is this direct effect? The direct effect will have a brief prolongation. Ano siya class? Nani siya graph? A brief prolongation. While this autonomic napata sa direct. So brief prolongation, then right after na ay shortening. And then mukal siya spelling flat 2. Mukal siya flat, if I'm right, hindi check. No? The electric conductance of the digoxin would lead to direct at autonomic. Indirect, there's what you call brief prolongation. Kalsa ka siya galit, and then modalin siya shortening flat 2. And then what is the idea of shortening flat 2? It decreases action potential but increases potassium conductance caused by acetylcholine. For the autonomic naman, this is, when you say autonomic, diba class, more siya baroreceptor. So we have two actions here, sympa tsaka para. Sympathetic effect leads whenever there's a high dose of digoxin. Parasympathetic naman would lead the effect of the electric conductance of the heart when there's a low dose of digoxin given. So duha iyang effect. Okay, so for this one, let's talk about its toxicity. Naa siya two types of toxicity, the heart tsaka the GI. So GI na siya class. So for the heart, we have the atrioventricular junctional rhythm. Tapos tayo premature ventricular depolarization. And then we also have bigeminal rhythm. Mausap yung class mga rhythm. So what is that rhythm? Connected na siya sa arrhythmia. And then the patient will also experience ventricular tachycardia, no, cold contraction man siya. And then aside from that, the patient would also feel atrioventricular blockade of the heart. So peligro siya, no, bisag sa heart siya mo effect na po siya mga side effect pod nga peligro pod sa heart. That is why this drug is very highly monitored. Di siya pwede nga matong butika tapos maintenance na na ma'am. We should still ask the patient if kano sa siya kutob, nag-monitor pa ba siya sa doctor, because this is their health. We're not up to the money but for their health. So next sa GI, prone siya for anorexia, and then nausea. When you say GI, more common than nausea, vomiting, and then diarrhea. Siyang DAD class. DAD. Muna kong clue for the GI, DAD. D for distress, gastric distress. So spelling distress. So when you say distress kay, muna yung component nausea and vomiting, and then you have to include anorexia tapos diarrhea. I forgot to include nga, since this is very highly pwede siya makasud sa CNS. There's a high CNS activity. Na po siya CNS activity dahil. So there are 3. The CNS includes disorientation, mo na siya. Tuwing na mga hallucination, disorientation, hallucination, and would even lead to gynecomastia. Yes, class, mo na siya. And then there's based on research, no, kay hyperkalemia daw reduces the enzyme inhibiting the actions of cardiac glycosides. Kay imong gi-stop no yan dili makasud sa potassium, so dahag potassium sa gawas, no, and then mulid ni siya hypokalemia kay wa na may potassium makasud sa cell. So there are studies says that kung you increase the potassium inside the cell daw kay ma-reduce daw ang enzyme action of the cardiac glycosides. Also kanin si calcemia, hypercalcemia kay maka-increase sa risk for induced arrhythmia. Diba na tay bijuvenile rhythm, premature ventricular depolarization, atrioventricular junctional rhythm. So this one are one of the reasons why kay tungod man taas man si calcium sa diri nga situation, tungod kita si calcium diri nga situation kay risk siya sa digitalis induced arrhythmia. Digitalis induced arrhythmia. Okay? Ayan, muna siya. So, let's go to the other drug. So, this is with inotropic. Then this is the without. Okay, for the inotropic, we have the family bipyridine. Okay, bipyridine, that includes the drug melrinone, also enamrinone. These drugs are PDE3 inhibitor. Take note, 3. They are capable of increasing CAMP, thereby increasing contractility, and vasodilation. So, contractility sa heart, vasodilation naman sa vessels. Okay? So, they are termed vasodilators. So, the pharmacology behind this one, it increases myocardial contraction, which increases calcium flux, alter intercellular calcium movements by influencing the they increase calcium flux, and then taas pud ang intracellular movements by iyang mangsipsip siya sa CSR, iyang bagay kung calcium diapay. So that is why PDE, murag PDA. So iyang i-alter niya intracellular calcium by influencing the SR, sarcoplasmic reticulum. We also have beta agonist. Yes, class punsa. We have the dobutamine. Dobutamine, as we have learned, that is the DOC of cardiogenic shock, right? So this drug class increases cardiac output, and it increases cardiac output while decreases ventricular filling. So the idea here, class, kay bisag musaka man niya ang cardiac output niya, agonist man siya. In the long run, hindi man siya pwede gyud nga magpermi. This rin siya, emergency case na ni siya. Kay if magpermi gani siya, prone na po siya for mga arrhythmias or any malfunction sa heart because of the too much push. This is in, so siya nga beta 1, right? Yes, beta 1. So muna siya. And we also have the other investigational research drug. Investigational research drug, these are the istaroxime, levosimendan, and the sa itong usa? Hindi ko makuha sa usa. Sa itong usa lang ito. Omecamtiv. Kindly check if sa class. Omecamtiv, Mecarbi. Let's say Mecarbi. Kindly check. This is still hindi ko sure. So, istaroxime plus. This is like a digoxin drug. Kaya i-inhibit ang sodium potassium ATPase. Okay. It's sequestration of calcium. While si levosimendan, this synthesizes troponin system. Di ba remember ka sa last part sa calcium natin, no? Kay sa last part sa calcium, kay the calcium sensitizers react with the myosin with troponin para there would be contraction. So here si levosimendan synthesizes troponin system to calcium, decreases PDE. While here omecamtiv activates cardiac myosin, prolongs systole class again that involve contraction, right? Tapos decreases without increasing oxygen consumption. Omecamtiv, but this is not common, no? Wala na kayo siya ginagamit. And then that's it. For the inotropic drugs class, we have the digoxin, the piperidine, the beta agonist, saka si Leo. DBB Leo. Pwede na po og BBB, si BB Leo. So, for the, this is like clue class. For the inotropic agents for heart failure, we have the BB Leo, the beta agonist, which is the dobutamine. We also have the piperidine, which are the Melrinone tsaka inamrinone. D4, what is D? D4 digitalis or digoxin, which is the drug used in the market. Then we have the levosimendan, istaroxime, and then the omecamtiv. Okay? So, sa drugs nga, wala na may effect sa inotropic. Drugs without inotropic effect are the number 1. Main reason nga nito kay mo cause ba to if naay problem sa left kay di ba pulmonary edema, so right, kay peripheral edema. So, let's try to erase the edema by giving the drug diuretics. When you see diuretics class for heart failure, this is the DOC for the drug without inotropic effect. Kaya pagkituod lagi taas og water sa heart, wala na naka-pump ang heart, so magstay dito ang water. So if we give the drug diuretics, what happened? It decreases salt in the body, salt and water retention, thereby decreases edema and also decreases venous pressure, and then it decreases ventricular preload. Okay? Since wala man siya inotropic effect, wala siya connection sa contractility. And then what happens next? For systolic failure, it decreases cardiac size. Pwede pagit siya mo gamay class if na ay problem sa heart, na ay cardiomegaly, kay one of the ways to lower the size is to give diuretics or give the patient resting time. Di siya pwede ma-stress, and then lang siya, lesser workload. So here, it decreases cardiac size, thereby what happens next? Pump efficiently. Then for hypertension naman, if patient with heart failure tapos na hypertension, it decreases blood pressure, thereby decreasing afterload. Okay? Since class, there are also reasons nga na-i-roll si aldosterone ani nga system. Since kung si aldosterone kay malmusa ka man iyang salt retention, thereby ang mga researchers or mga pharmacologists or even the scientists or both kay nag-research sila, pwede siguro ta maghimo og aldosterone inhibitor para dili musaka ang salt, kay usa gyud ang salt sa maka-problem sa heart, kay musaka man sila ang water. So here they try to test spironolactone spironolactone, and eplerenone. Okay? Si eplerenone, mo na siya. Okay class, mo na siya si aldosterone inhibitor, mo na sila si spironolactone, tsaka eplerenone. Di na siya magstay. So, decrease sodium retention, thereby decrease water retention. The problem ang good if we let it if we don't fix the sodium retention, the baroreceptor reflex in the brain, in the carotid sinus, kay ano siya, malfunction, thereby increases positive mechanism instead of negative mechanism. So ganon. There's also what you call gas investigational drugs. Under this is the phenerenone. Okay, so they likely induces hyperkalemia. Yes, it increases potassium inside the heart. In fact, aside from that class, aside from diuretic, drug class that are responsible for trying to correct heart failure, or trying to lessen the symptoms of heart failure, is the vasodilation or vasodilators. So under vasodilator class, we have the drug hydralazine. We also have ISDN. We also have the Niseritide. So first, before digging the theory, what are the action of vasodilators in the heart failure? So vasodilators give effect by decreasing preload kung magdilate sa mga veins. That is what you call venodilation. So decreasing preload in the venodilation, and then also it gives effect in decreasing afterload in the arteriolar dilation. You have to think class, when the heart, no? Diba, naman to? So, si left mo man siya ang receiver from the body. So, when you say from the body, vena siya, diba? Back to the heart, and then kaya si aorta to the body. So, mo-decrease gyud si preload, kay dili man mag-start og receive ang heart from the body. So, venodilation. And then, kung arterial naman ang dilation na afterload, kay ano naman siya, padung naman siya malabas. Gets niyo class? Okay, so there are other drugs under this one, the hydralazine and SDN. Kung vasodilate man siya, discussed in the angina, right? So it reduces the remodeling or the modeling of the heart. Kaya ang heart yung mag-push naman kayo, ganoon naman siya mag-pump, itry niya pump yourself until nausog na yung phase. So these drugs, i-vasodilate niya, lower niya ang preload, i-lower niya ang afterload, thereby decrease ang case nga mag-remodel ang heart. And then, we also have Niseritide. So, before talking about Niseritide, di ba, katong, ningon ko sa class nga, ang heart gani class, kay, ano na siya, parang wala na yung kagawsanan sa yung debate, kay tanan na lang, error na lang tanan. So, the heart here, ma-full load, di ba? Ma-full load, thereby mo cause shock modeling. So, other ways niya, para mo compensate, kung nahimo na ganyan tanan niya, wala gyud pa resulta, the heart would release increased BNP. These are peptides, nga, ma-check ka na to. This is the you call that marker. Yes, marker na siya nga na something wrong na gid sa heart nga. Pradol na gid sa heart failure na gid siya, increases BNP, thereby causing a little bit good thing inside the heart. Imo iyang i-lessen. So class, the purpose of BNP, ANP, the natriuretic peptide in the heart, kay they have the capability to regulate the circulation. They may dilate and relax the tone para mo give a little bit compensation sa may tabo sa iya, kay wala na jud siya kagawsanan. So that is good, no? And tungod kay wala na may other ways nga mo mahayahay ang heart mo na mo gawas na lang po, wala na may silbi. So here, this BNP increases. That is why whenever there's an increase in BNP, makasense na dahil ang mga doctor nga is nigawas na gyud siya, pasabot kinana gyud ni pasabot nga there's an increase percentage nga nanay heart failure patient if mugawas ni siya. So it becomes a diagnostic or prognostic test marker for patient with exacerbating CHF. Okay? So the problem there lang kay BNP is this is degraded. So ma-degraded ni siya. So magkuba siya by the enzyme neprilysin. Okay? Yes. What is neprilysin? This is the neutral neutral endopeptidase enzyme. Again, neprilysin is a neutral endopeptidase enzyme, so responsible for degrading BNP. That is why class na drug ani niya nga mo combat ni neprilysin. But before that, no, nagtabi man tanin ni Sineritide. So Sineritide class, na siya. This is approved for the use of acute, not chronic cardiac failure. Okay? As in, vasodilator siya. So this is for chronic, dili pwede acute. Okay, it reduces venous tsaka arteriolar tone. Also increases diuresis. So very good din si Sineritide. Ang problem lang kay based on the clinical studies kay wa siya ni give good effects sa pinaka level of treatment sa tunga stage. So dili siya pwede, wala na siya. So today there is what you call the drug nga i-try sila increase sa BNP. They are trying to make BNP last inside the body. Pero nalagi si neprilysin. That is why drug now tries to combat neprilysin. Who are these drugs? We have the sacubitril class. Sacubitril, sucabitril. Try to check class. Kani siya is very important ni siya sa market. We have the drug Entresto. But ano siya? Naan siya together it is bonded with ARB. Okay? Gi-combinean siya ARB because during this clinical phases kay it gives good effect. Good results. Okay? Again, let's go back for the vasodilators class. Hydralazine. So, vasodilators for heart failure kay vaso ni for Niseritide, tapos ISDN, and then hydralazine. For Niseritide, kay ano man siya, good for decreasing venous tone o increase the diuretics. Pero ang problem lang kay wala siya ni-give good effect sa research, no, upon longer studies kay wala siya ni-give a good effect. Aside from that class kay since short half-life ni siya, si Nessie, kay short half-life, when you say short half-life class, dili na mawala yung effect. Mo na siya nga, if given sa hospital kay, at first few minutes kay, ihatag siya bolus nga dose. Kasi bolus class, dako na siya nga dose. And then right after that kay, continuous na nga infusion. So, in that case, no, diuresis man siya, sige, diuretic, tapos infusion, na dyan siya cases nga, renal damage. Na decrease po ang tone, possible po nga excessive decrease of hypertension. Mo na si Nessie. Sobra kabuutan mo na naitabo siya. Magka-renal damage, too much decrease of hypertension. That is why nigawa si sucabitril plus ARB. Then upon studies kay good results ra siya. So mo na ginagamit until now. This is very good for patient with HF, REF, reserved heart failure. Okay? So sa pamay aside ana. Naapoy another related peptides include ANP. So related peptides nga makakause og vasodilaton. These are the ANP and urodelantine. So ano siya class? It is produced in the kidneys. We also have the drug carperitide and ularitide. Investigational drug yapon ni siya nga synthetic analog for the peptides. Okay, synthetic analog for the peptides. But still, under investigational drug pa man siya. So, until gyapon. And then we also have the drug bosentan and tezosentan. Kanang these two class kay okay ra unta ni sila pero gina-take out ni sa market kina labi na si bosentan kay naa siya hepatotoxic effect. And teratogenic effect. Okay, so wala siya. Disappointing. Okay, so that stops the vasodilators. Aside from the drugs of diuretic at vasodilators for drugs without inotropic effect, we have the beta blocker. Again, too much pumping, no? Too much contraction. Inducing contraction would lead to remodeling. So that is why we give these beta blockers para mo decrease mo regulate sa nodal, di ba? It is ano siya mo target siya sa SA node because we are trying to target the B1 which is responsible for the heart rate, the chronodromo, and the ino. Okay, for the beta blocker, since it blocks the inotropic effect, it belongs to the no inotropic effect. So included drugs here, the bisoprolol, carvedilol, bisoprolol, carvedilol, the metropolol, nebivolol. Again, nebivolol, the very cardioselective. So there is a drug, bosindolol. This is not included. Okay, for this one, this high concentration of the catecholamines which are responsible for the inotropic effect is decreased. Decrease high concentration of catecholamine. They also stops apoptosis. That is usually happen inside kung grabe na ang heart failure. Okay? So other than the drugs, ginagamit po nato ang mga aliskiren. Hindi na masulod. We also have the drugs, mga ARB, ASI. So example drugs involved here for ARB are the candesartan, ASIE, that is mga captopril. And then we also the renin inhibitor is also incorporated in this one. So under clinical trial they are good, but this is not much common in the market, so dili kayo siya. So we have the aliskiren, the renin inhibitor. So renin kay responsible man siya to increase hypertension. That would lead to increased sodium retention, diba? So cutting all those mo good sa heart. So that's such a good thing. So aside from that, other drugs are the semaglutide, liraglutide. This will be discussed on another topic. This is morely focused on the diabetic. So empagliflozin, SGLT2 inhibitor. Try to understand the categories kung asa siya belong. So semaglutide, liraglutide, GLP-1 agonist, and the empagliflozin. Okay, so again for inotropic class, for inotropic effect we have the BB dileo. So BB bypyridine, beta agonist, bypyridine, beta agonist, digitalis, digoxin, L4 levosemendan, estrazoxime, estaroxime, sige, digoxin, levosemendan, hindi sa palito class, estaroxime, and then O4 omecamtiv mecarbil, and then without inotropic drugs class kay sige babada. For inotropic drugs class, it includes B4 beta blockers, A4 aliskiren, V4 vasodilators, A4 ACE inhibitor, D for diuretics, A for ARBs. So if you try to extract the meaning of the babada, B4 the beta blockers. Beta blockers includes sa tawag sa beta blockers mga bisoprolol, carvedilol, metropolol, nebivolol. Basta walay labot si bosindolol. So bisoprolol, carvedilol, metropolol, saka nebivolol. ACE inhibitor, kinsa to? Si captopril. Si vasodilators, that includes hydralazine, Vasoni, di ba? Vasoni, and for niseritide, I for ISDN, H for hydralazine. Aside from that, kasi niseritide, kay naman siya yung bad part, it is now being used by sucabitril. Sucabitril, I really think sacubitril na siya. Let's try to check na lang, ha? And then G for another A for ARBs isa na siya diya, C candesartan. D for diuretics involved DOC. Who's DOC? It's furosemide class. Wala kang butang. Okay, furosemide and DOC. Aside from that, as a diuretics, we have the aldosterone inhibitor. Try to imagine na lang under the diuretics na aldosterone inhibitor, matulad si spironolactone, tsaka si eplerenone. Okay, and then D diuretics, A for aliskiren, which is a renin inhibitor. Okay, that sums up the drugs for heart failure.